God created us in His infinite mercy with two kidneys, although some people are born with one.
Some are born with one?
With one kidney, yes, and they survive. Kidneys will literally lose about 90% of their function before they start to warn you that something is wrong. This is because if one kidney fails, the other kidney undergoes compensatory growth, something we call hypertrophy, to compensate for the other kidney. This is why when people are born with one kidney, they can still survive. This is why you can donate your kidney and still survive. Each kidney has a cell, that makes up the kidney, the functional unit called a nephron. It's the nephrons that do the work of the kidney, like filtering blood, removing waste, all that. Each kidney has like 1 million nephrons, and you have two kidneys. The other kidney can actually grow and take over the job of the other kidney. So because you have two kidneys, as your kidneys are being injured, they're losing their function, they try until they can't try no more. Do you understand? So kidney disease does not manifest itself. It is when they literally cannot do anymore. And that's about when you lose about 90% of your reserve. That's when they start to show. And that's why we call it a silent killer. Diabetes is the most common cause of kidney disease worldwide, but in Nigeria it's hypertension. So as a Nigerian, a lot of us, we're actually walking around with hypertension and we don't know, because it doesn't really.
Hello everyone, welcome to an episode of TooHealthTalk. It's your good sharing this and it's breaking like a very simple and honest conversation. On today's episode, before we go on, please, for you to support what we're doing here, please subscribe to this channel, like and share to someone that might need this video. On today's episode, we have a very special and giant mighty guest with us today, Dr. Maryam Ahmed Almustapha. Welcome to our show, Doctor.
Thank you very much for having me.
Thank you so much for coming on the show with your busy schedule. Make our times even though you're also going to work today.
Yes, I'm dressed for it.
Well, thank you so much, Doctor.
You're welcome.
Dr. Maryam, she's a special doctor in nephrology department, and I'm so excited to have her on the show because this topic is a very, very important topic that we get to see every day in the 4 walls of the hospital. So now, in your career, most many people will not even know you because I know you. For those that are seeing for the first time, can you give them a brief knowledge about yourself?
Okay, so my name is Dr. Maryam Ahmed Almustapha. I am a medical doctor here in Nigeria with a special interest in nephrology, but I also double as a health educator and medical content creator. I have my YouTube page where I have medical examination videos for medical students as well as health videos for general public. I'm also active on Instagram, Facebook, and TikTok where I make everyday health videos to demystify health problems in Nigeria. So that's about it.
Yeah.
Short introduction.
So today we're talking about diabetes and hypertension
on the kidneys. Yeah.
On the kidneys. Yeah. So now in your time in being in the 4 walls of the hospitals, how do you tackle these issues of hypertension and diabetes?
Okay. So for me specifically in nephrology, I would say about over 50% of our patients have hypertension and diabetes and are in our care because of the hypertension and diabetes, meaning hypertension and diabetes are the biggest causes of kidney problems. So most of our patients do. And right now, because we're in Nigeria and because of our economic situation, as most of us can relate to, healthcare is not exactly cheap, especially for patients with advanced kidney disease, because kidney disease can be a very, very expensive illness. So taking into account the cost of drugs and then, God forbid, these patients progress to have advanced kidney disease to the point where they may need interventions, it becomes very expensive. So our role mainly right now is to focus on prevention. So we have noticed that picking up these patients early, putting more eye on them, if you can say that, screening them, and then giving them necessary care that they need before they reach kidney disease complication is basically what everything is about right now for us. That's our emphasis.
So now, in your career time in the nephrology department, is there any moment that changed the way you see patients?
Yes, exactly. So going back to healthcare is not cheap. I have had so many patients that could have survived, could have done well on dialysis or renal replacement therapy, but unfortunately could not afford it. So as doctors, we tried our best. Do you understand? Sometimes we even have to donate out of pocket. Yeah. So seeing these patients that they just need this one thing, but they could not afford it, leading to them losing their lives is very, very devastating. So as nephrologists, like, that's the part that we don't want to see. That's why, because we know of the economic challenges, we try to focus more on picking these patients up early and focusing more on prevention and giving them care before they reach the extreme ends of the disease.
So now let's go back to the starting points, like to the drawing board now. Hypertension and diabetes destroy the kidney. Yeah, we already know that now. Okay. So now, what is the cause of this hypertension and diabetes?
Okay, so do you want me to start with one? Let's start with one. Okay, we can start with hypertension. 90% of hypertension is essential hypertension or primary hypertension, meaning we don't actually know the cause. Patients just have hypertension. There are risk factors, for example, age, race, being black, male gender, diet high in salt, some genetic risk factors, family history, all that can predispose, but we don't actually know the cause of 90% of hypertension. And then there's the 10% that we call secondary hypertension. This is when we actually know the cause and we can do something about it. This is for patients with like chronic kidney disease is one of them. Endocrine diseases like thyroid problems, adrenal problems, and then other structural abnormalities of the heart. Even drugs, for example, like cocaine, amphetamine, all that, they can cause secondary hypertension. When it comes to diabetes, we have two types of diabetes, type 1 and type 2. Type 1 is an autoimmune disease, meaning it's the body attacking itself. So usually it's seen in younger children. What happens is that usually there is some abnormality where maybe, for example, they get a viral infection that's very, very mild. And then while the body is trying to protect against the virus infection, as it's making antibodies, it also makes antibodies against the pancreas. The antibodies go and destroy the pancreas, and then these kids end up with no insulin, which is what we need to utilize and metabolize glucose. So they end up having type 1 diabetes. Type 2 diabetes, on the other hand, is almost not hereditary, but it has a very, very strong family history. Unlike type 1, it's not due to insulin deficiency, it's due to insulin resistance. So you usually see it in older individuals that are obese. They have some level of insulin resistance whereby the insulin is present, but it cannot make the cells utilize and metabolize glucose. Oh. So that one has a stronger family history, actually, almost 90% in twins, and in twins, yes. Oh. Unlike type 1 diabetes, yeah.
Oh. So now I picked the point when you're talking about hypertension. You said gender, which is male gender. So you're saying that 90% of men is liable to die of hypertension?
No. 90% of hypertension is essential hypertension. So the essential hypertension, we don't know the cause, but there are risk factors. Among the risk factors is male gender. So but not that women cannot get hypertension.
So mean as a man, I already know that.
You have a higher chance of getting hypertension than a woman, yes.
Voila for a woman. Well, so now, yeah. What's like one moment that, that touched you the most, seeing patients with hypertension and like leading to kidney disease?
Okay, so going back again to, I had this one patient that came in, very, very young patient that had end-stage renal disease. They couldn't afford dialysis. And unfortunately for him, there are two types of, you have rescue dialysis or acute, where you just temporarily need the dialysis. Then there's maintenance dialysis, where you need it to maintain your kidneys. He could not afford it, despite all our efforts. At the end of it, I think they had to leave the hospital early to go get funds, but then at the end of the day, he developed acute pulmonary edema, which is one of the complications of patients with end-stage renal disease who are not regular with their dialysis, and he didn't make it. So when I see things like that, I'm just like, these are young patients that really could do well on renal replacement therapy, just that it's the funds that don't have. And unfortunately, we don't have like subsidy on dialysis here in Nigeria. I would like to encourage the government, if they can't, this is something that's very, very important. They can have programs, make dialysis at least 50% or free for Nigerians, because this is something really heartbreaking that we see every day, and it's likely to continue unless we find a solution to it.
So now, if you're going to do your dialysis, is it once every week, once every month, or how do you do dialysis?
Exactly. So it depends on which type of dialysis you have. For patients that are having acute kidney injury or an acute picture on top of their chronic injury, meaning the renal function can get back to a level where it can sustain them. They only need a few sessions, maybe around 1, 2, 3 sessions, for you to manage the complications that they have as a result of the kidney injury, giving the kidneys time before they pick up. But for patients that have end-stage renal disease, that means they have essentially no residual kidney function, and they rely on the dialysis to do the work of the kidney. So for those patients, the standardized program is dialysis 3 times a week.
3 times a week?
Yes, average of 4 hours. So you can imagine somebody that has chronic kidney disease, he is spending 4 hours in the hospital. That's even if the moment he goes to the hospital, he gets to dialysis, because the reality is a lot of our patients, they go to the hospital for dialysis and wait because there's a line due to lack of dialysis machines, which is a reality in Nigeria. So they end up spending essentially the entire day in the hospital.
Interesting.
Before they get on the machine to spend 4 hours. And then they have to come back 3 times a week again. Like they have to have it 3 times a week for them to actually have, to be symptom free. So I think there are other programs. For example, when I was in Kano, AKTH, they have this system where people go in the night. So for example, for people that work, it's more flexible for them to just go have their dialysis during the night, so that during the day they can.
Wow.
But then again, not everybody can afford. So a lot of our patients are having to push through life with 1 or 2 sessions of dialysis per week, and which is often not really enough to keep them symptom free.
Oh, that's a lot. So now, like, how can someone watching this stuff now, like, this stuff you already said now is very, very scary.
Mm-hmm.
So how can someone listening to us today now prevent getting kidney stones or having kidney diseases?
So my urge to anybody watching this video is, you people have to be very, very health conscious. There is something called medical screening, okay? For every individual that is over 18 years old, whether you're a man or a woman, there is no excuse as a Nigerian for you not to be checking your blood pressure regularly. Diabetes is the most common cause of kidney disease worldwide, but in Nigeria it's hypertension. So as a Nigerian, a lot of us were actually walking around with hypertension and we don't know. Because it doesn't really say, come on and say, hey, I'm hypertension, I'm inside you, you understand? So it just comes with complications. So we don't have excuse just to be sitting around living our lives, going 5 years without checking our blood pressure, without checking our blood sugar. So we should enroll ourselves in screening programs. This should be out of pocket, because I don't think we have like a generalized screening, unless like during outreaches. For example, sometimes for nephrology, we do outreaches where we check blood pressure, sugar, urine, blood tests. But you as an individual, you should have the responsibility to say, okay, this year I've not had a medical checkup in a long time. Maybe every year I'll be checking my blood sugar, my blood pressure, my urine, and some blood tests, essential blood tests, which include kidney function. Because we are seeing a rise in chronic kidney disease among young adults.
Wow.
Not because of hypertension or diabetes, because of something completely different called chronic glomerulonephritis. So sometimes just because you don't have blood pressure or high blood sugar doesn't mean you're safe, which is why screening is very important. In fact, a lot of patients now, I would say, I have some patients under admission that up to 50% are individuals below 40 years.
Wow.
Yes. I have somebody that's 25, somebody that's 30, 33, all of them end-stage renal disease.
Are you sure it's not climate change? Or what's that?
You can blame it on a lot of things, because chronic glomerulonephritis is a disease, is an umbrella term that can be caused by so many things. It can be contamination from metals, it can be hereditary, it can be from simple infection, throat infection. Do you understand? It can be autoimmune disease. So it's just an umbrella term. But unfortunately, by the time that we pick this disease out in young adults, it's end stage, which is why screening is very, very important, especially for patients that have family history of hypertension, of kidney disease, of diabetes. So I just want us to be more health conscious, okay? It won't kill you to check your blood pressure. Okay, this blood pressure thing is really paining me.
Wow.
Because it's something that you can easily detect. Sometimes with 1 drug, 2 drugs, you control the problem. But then people let it linger inside them to the point where it kills their eyes, kills their heart, kills their kidneys, causes so many problems, and then the financial implication goes through the roof.
True.
Next thing you know, somebody comes with hemorrhagic stroke. You're paralyzed, and then then you go into chronic kidney disease. Like, which one do you deal with? Do you understand? Just take 5 minutes. Get somebody to check your blood pressure. Get somebody to check your blood sugar. And then every year, try to do general medical screening. A checkup. Check your bloods and your urine.
mostly this our generation, like we're almost like focusing the hustle, like want to hustle, want to wake up, like midnight late, like there's so many pressure, like in this our own generation. I don't really know if we are making a lot of awareness. They'll be like, okay, as far as you are working hard to make money, please make sure you check your health.
Exactly, because at the end of the day, if you die and you make money, what's the point of the money if you die? Do you understand? True. So it's good that people are hustling. You need to make money, you need to eat, but at the same time, that money won't matter if you're dead. So it's very important to know that yes, as much as I'm hustling, I also need to take care of myself.
Sure. Why do doctors use the word silent killer when referring to kidney disease?
Okay, so God created us in His infinite mercy with 2 kidneys, although some people are born with 1. Okay,
some people are born with 1?
With 1 kidney, yes, and they survive. I get to the point to understand why they survive. So each kidney has a cell, that makes up the kidney, the functional unit called a nephron. It's the nephrons that do the work of the kidney, like filtering blood, removing waste, all that. Each kidney has like 1 million nephrons, and you have 2 kidneys. So the way God structured it, and this is what I really appreciate about the kidneys. I have so much love and passion for nephrology. It's because the kidneys are so resilient. Okay, it's not like the heart where small injury, chest pain. Do you understand? The kidneys will literally lose about 90% of their function before they start to warn you that something is wrong. This is because if one kidney fails, the other kidney undergoes compensatory growth, something we call hypertrophy, to compensate for the other kidney. This is why when people are born with 1 kidney, they can still survive. This is why you can donate your kidney and still survive. We're looking for kidney donors, by the way. Okay? So this is because the other kidney can actually grow and take over the job of the other kidney. So because you have 2 kidneys, as your kidneys are being injured, they're losing their function, they try until they can't try no more. Do you understand? Yeah. So kidney disease does not manifest itself because you don't even know what your kidneys are doing for you. It is when they literally cannot do anymore. And that's about when you lose about 90% of your reserve. That's when they start to show. And that's why we call it a silent killer. That's why it's very important to be proactive when it comes to your kidneys. Okay? You have to look for the kidney problem. Don't wait for the kidneys to tell you that they have a problem.
Wow. So now, how you mentioned about someone having they born with 1 kidney. How will you know they gave birth to you 1 kidney? How will you know they gave birth to you 1 kidney?
That's the thing. You'll never know. I had 1 patient.
You'll never know.
You'll never know. I had 1 patient that I was referred to my clinic. She just went for a random screen. I think she was having 1 abdominal pain. She had malaria, and they now decided to do scan. As a screening, they now found out she had 1 kidney. Wow. She never knew about it. Do you understand? So that's why it's important to do general medical check. Sometimes you don't know what you're walking around with inside your body. That's why it's important to check. But she's doing well. At least that's something. But she's
so now anybody that wants to, advise everyone to go and check if their kidney is complete.
Yes, exactly. That's a good first place to start. You could check if you even have 2 kidneys.
2 kidneys. I think this is the first time I'm hearing that they can give birth to you with 1 kidney. Yeah.
Yeah.
Wow. Okay, please, if you're listening, you need to go and check if you have 2 kidneys or 1 kidney. Because most people do not even know that, they can give birth to you 1 kidney or 2 kidney. So now, the damage for having damage in your kidney or having some wounds in your kidney, when is this damage going to be irreversible? Is there a point where they cannot get this person back?
Yes. So, there are steps in kidney pathogenesis, meaning kidney disease before it goes to end stage. We have step 1, step 2, step 3, whatever. The first step is usually something we call hyperfiltration. So what this means is, you remember the compensatory hypertrophy I told you about, that the kidneys work harder when something is in trouble. Yeah. So this, in the nephrons, sometimes the first step is a stage of hyperfiltration, whereby the kidneys are injured in particular. So for example, in diabetic kidney disease, it causes kidney disease in a way that the exit vessel of the nephron, called the efferent, is affected more than the afferent. So that causes increased pressure in the glomerulus, which is the kidney. That causes a state of hyperfiltration. So normally the kidneys just filter blood. they filter up to 180 liters per day. That's a very interesting fact. People think their heart is working hard. Imagine what your kidneys are doing for you. 180 liters of blood every single day. So, but in a state of hyperfiltration, they go even more than that. So you can see how that can be dangerous long term. So if you keep your kidneys in a state of hyperfiltration for a long time, you're increasing their stress, increasing their damage, increasing scarring. And at the end of the day, you get end-stage chronic disease. So if we can pick up people at this hyperfiltration stage, it's reversible. Because if you take away the insult, the kidneys can go back to their normal filtration rate, and then the stress will significantly lessen on them, and then they will not have to have those injury, nephrons dying, scarring, all that.
Wow. So how long, if for someone that has an uncontrolled diabetes, how long does it take for it to result to damaging your kidney?
So it depends on whether it's type 1 or type 2. Type 1 diabetes presents, so when somebody has type 1 diabetes, you'll know immediately. Even if not immediately, you will know within a short period of time, because absolute insulin deficiency, meaning if they have no insulin at all, it will come to you. They'll come with a complication, maybe DKA or something like that, so you will find out. So for type 1 diabetics, people with type 1 diabetes, it takes about maybe 5, 10, 15 years. So you know you have adequate time to control the sugar or whatever. The issue with type 2 diabetes is because it's not that they lack insulin, it's that there's insulin resistance. So they don't come and tell you, I have type 2 diabetes. Most people with type 2 diabetes come with a complication. So somebody might be living, the first sign is kidney disease. Is when you go retrospectively and you look back in his history that you now realize that, he had diabetes, he was so. Wow. Most patients with type 2 diabetes present with a complication, unlike type 1 diabetes that come with, they come with the complication of diabetes, but it's strictly related to the diabetes, like the organ itself, the pancreas. Or like type 2, where it's now multisystemic, they're coming with different complications, MI, stroke, chronic kidney disease, peripheral neuropathy,
Yeah, so now, for this diabetes now, some people get to treat diabetes, but still end up with kidney disease. Why? Because
the kidney disease is multifactorial. You can treat your diabetes and achieve good blood sugar control, but it might have been too late. Maybe you had so many years of hyperglycemia you didn't control until the kidney disease now fixed it, until the kidney disease now occurred, and then now you're getting normal blood sugar levels. Do you understand? Wow. So now that you decided to be serious, it is already too late. The second reason is that there are other confounding factors. For example, hypertension, obesity, use of recreational drugs. Do you understand? So if you control the sugar, but the BP is not controlled, or the proteinuria is not controlled, that where your kidneys are leaking, you can still have chronic kidney disease. Do you understand?
I've seen something, I'm thinking of what I saw that, I think on Twitter, yes, I saw someone tweeted something. The person was talking about, her sister or her cousin called off their wedding because of, they found out that the mother of the groom died of cancer. And that she's scared that the cancer might, it's hereditary, something like that. Is this same for kidney?
No.
Like if somebody in somebody's family died of kidney diseases, and is this something that people should be scared to marry from family that their relation died of kidney disease?
Okay, so just to address that Twitter issue, that's completely baseless. There are some cancers that are hereditary, cancer syndromes. They are just cancers. There are some cancers that are sporadic. Do you understand? Somebody can have cancer in the family and then nobody else has cancer for the next 3 generations. But then you can have certain cancer syndromes that are inheritable. Do you understand? So it depends. For example, just because somebody has cancer, majority of people that have cancer, they have cancer in a sporadic form, not a familiar form, meaning it doesn't run in the family. A very, very small percentage runs in the family. When it comes to kidney disease, there are some cancers of the kidneys that can be heritable. It's one of the things. You can have genetic diseases like von Hippel-Lindau, tuberous sclerosis, that you can have kidney disease. You can have kidney cancer with it, and then you can have kidney disease that runs in the family. For example, a structural type of kidney disease that we call ADPKD, meaning adult autosomal dominant polycystic kidney disease. So people are born with cysts in their kidneys. So even that counts for a small proportion of chronic kidney disease. So you can't really stigmatize people that, because they have cancer or because they have kidney disease, because majority of the cases that occur, they come in isolation, not that will have, if I marry this person, I will give birth to a baby that have, do you understand? Unless there is a documented familial disease or inherited disease in the family that runs in the family.
Wow. So you've talked about type 1 and type 2 diabetes and how it can lead to kidney diseases. Now, for hypertension, is there a specific type of hypertension you guys look at that can lead to kidney disease?
Well, yeah, all kinds of hypertension. If not treated, the issue is not because of the hypertension, it is the hypertension itself. Having hypertension is like giving excess work to your blood vessels. In response to that, what happens when you exercise a muscle? It thickens, right? That's the point of people going to the gym. Yeah. You have smooth muscles in your blood vessels. So when there's high blood pressure for a prolonged period, there's thickening of the blood vessels. That reduces blood flow to the kidneys. And kidneys are very, very vascular organs. Because they filter up to more than 180 liters of blood a day, they take a lot of the blood coming from the heart. So they need to feed themselves as well. But when you have long-standing hypertension, the vessels of the kidneys can become thick. That can reduce the blood going to them and lead to ischemia, which is basically when your kidneys are deprived of blood and they can't flourish. So that causes micro injuries, inflammation, scarring, and then to a point where your kidneys even shrink. Wow. So yeah. So
if now you've told us that high blood pressure causes kidney disease. I want to throw this question to you. Does kidney disease cause high blood pressure?
Absolutely. In fact, sometimes even as clinicians, we have challenges. When we have a patient that comes in with long-standing with hypertension and chronic kidney disease, we want to know, was it the hypertension that caused the kidney disease, or was it the kidney disease that caused the hypertension? And this is something that you will see that it's actually a real dilemma when it comes to clinical practice. So hypertension can cause kidney disease through the mechanism that we just mentioned, but then kidney disease itself in a patient that's not hypertensive can occur. So if somebody does not have hypertension and they develop kidney disease, hypertension can be one of the complications. Wow. Because the kidneys have many functions. One of the functions is regulating blood pressure through excretion of salt, hormonal mechanisms, all that. So when the thing that is supposed to control you, one of the things that is supposed to control your blood pressure gets knocked out, your blood pressure will go up. And unfortunately, renal hypertension is very, very difficult to control. Wow. Yes. So one of the clues is that usually when we look at if a patient has chronic kidney disease and they have had hypertension for like 10 years, 20 years, yes, likely it's the hypertension that caused. But then there are some things that we look out to support, like we look at the kidneys, understand the size of the kidney, the architecture, and we look at the urine as well to support, is it hypertensive nephropathy, which is kidney disease from hypertension? Or we want to see, is it that the patient developed kidney disease first, then is now having hypertension. Again, we look at the history. If somebody was diagnosed with hypertension 2 years ago and he has like end-stage kidney disease, it's unlikely that it was the hypertension that caused the kidney disease. But we also look at the sizes of the kidneys on scan, and then the findings in the urine, because the urine is amazing. It's like the gateway to the kidneys. You can discover a lot about your kidneys from your urine. Us nephrologists, we're always so happy to see urine. I know that's very weird, but when we go to patients and we see urine, we're so happy because it means the kidneys are working.
They talked about color. I think I saw a video about color of urine.
I made a video about that. I don't know if it was my video.
How does that work?
So, it depends. So, normal urine is the color we call amber. If it's more concentrated, it means you're just simply dehydrated. If it's getting brown or red, it means you're having bleeding, which can be microscopic or overt hematuria. That's the medical term, hematuria. It can also be drugs. Like if somebody has TB, they're taking TB drugs. There's a certain TB drug that can cause discoloration and all that.
So now, most people that don't urinate more often, like they don't go to the toilet to urinate more often, is it a problem with their kidney?
So everybody has a different body. Like, we are all different in terms of our bodies. So some people urinate more, some people urinate less. You have to know your own baseline function. So for somebody, it's natural for them to go to the toilet maybe twice a day. But in a situation where there's anything outside of your norm, then that's when you get concerned. If urine reduces less than your normal, it can be a sign of acute kidney injury. If you're urinating more than usual, that's called polyuria. It can also be a sign of kidney disease or diabetes or other things. But then technically, usually the normal urine in a day is about 0.5 mils per kg. per hour for an adult, or let's say like 500 mils in a day, like one sachet of pure water.
Wow.
But then like during the cold seasons, because there's a lot of vasoconstriction in the body, there's a lot of people tend to urinate more. Or if you're always in the AC 247, you'll find that you're going to urinate more because of the lot of vasoconstriction and increased blood flow to your kidneys.
Wow.
Okay. Yeah. So because that pushes more blood to your kidneys, filters more, you make more urine. And then during the hot weather is the opposite. But then it also depends on how much water you drink. But normally we say about normal urine output per day is about 500 mils per day, and then it shouldn't exceed more than 2 liters. That now becomes polyuria.
Wow. So now we are talking about urine now. Something just came to my head. For urine, where is urine coming from?
Okay, so urine is just basically your blood that has been filtered through your kidneys and comes out. So urine is like an ultrafiltrate of blood that contains all the waste that you don't need. So if this is your kidney, you have blood coming into your kidney, and then this blood has come out. So the blood that is coming out has been cleaned. All the waste and everything that you don't need comes out as urine.
As urine?
Yes.
Wow. So now, I want to go to somewhere now. Now you've explained this stuff now. Why would people put urine in the eye and say urine cures Apollo?
Me, I don't know that one.
But you've seen it.
I've not seen it before. Please don't put anything inside anybody's eye.
Like
their own urine?
Yeah, people do put urine in the eyes and say, oh, urine is to cure Apollo.
No, please, I beg, don't do that.
Because you just said urine is like a waste.
No, it's waste, and it has no this thing. I'm not aware of any anti-inflammatory properties of urine or any antioxidant properties of urine, so I don't know about. I've never heard of anything like that.
You've seen it. You're putting urine in your eye. That urine is
please don't do that.
Your eye, please don't do that. Also, for hypertension now. Someone that has hypertension for over 10 years and has been treating this hypertension now, is there a likelihood that this person will not have kidney problem?
Yes. So if no matter how long you have hypertension, whether it's 20 years, 50 years, as long as your blood pressure is under control, that's it. It's not the hypertension status itself. It is the hypertension, meaning the uncontrolled blood pressure. My father has hypertension for the last, I don't know, maybe over a decade.
Wow.
But it's well controlled. He has no issue. So as long as you have, that's why we put emphasis on compliance to medications. A lot of our patients don't like taking medications.
Sure.
We always tell them that as long as you take your medications, you'll be fine. Trust me, not taking your medications creates like a whole world of problems with financial implications, time implications that you don't need. So as long as people take their medications, even for people with diabetes, if they comply, if they are at target for both their blood sugar and blood pressure, they should be fine.
So now, is there a warning sign
for
like if you're having hypertension and diabetes? Is there a warning sign that this stuff might lead to kidney disease?
Well, so sometimes from the urine, if you're having frothiness, do you understand? But clinically, not very much. Do you understand? Mostly it's during screening. That's why I emphasize medical screening. So the warning sign is when you present yourself to be screened, and you're not feeling anything, or you find out that, oh, this one is having proteinuria, oh, this one's GFR or kidney function is like 60. Do you understand? Then we can say, oh, you're having early kidney disease, or oh, you're at risk of kidney disease, even though you are not feeling anything. But hardly is there any warning sign for kidney disease.
So now there's no sign in your urine now that you can look, my urine is shining this color, is it like this, or it's foamy?
Usually by the time that you're having those symptoms, you have most kidney problems. Kidney disease usually comes with symptoms when the kidney function has gone below 30 eGFR. Wow. So that's like stage 4, advanced. So by the time you're having decreased urine output, swelling in your legs, swelling in your face, hiccups, all that, it means you've already progressed so far. Do you understand? No, I don't really consider that a warning sign. Warning sign means something that you can potentially reverse. Do you understand? So that's why it's very important. Sometimes frothiness, that's the only thing I can think of. Frothiness means proteinuria. So if we can pick that up, and your kidneys are still working, if you control the proteinuria, you should be fine.
Oh, so now for those that don't like going to the hospitals, what's the advice of it?
Please go to the hospital. And then there's something I want to point out to people. I understand that Going to the hospital is very, very inconvenient and it's not nice. Even me as a doctor, I don't like going to the hospital. When my family members are sick, I have to force myself just to support and go to the hospital, but I don't like. So a lot of people resort to just, convenience, pharmacies and stuff. Not that, so the thing is you have to be very cautious. And I'm telling you this story because I've had a few patients that came to me, or a consult was sent to me to review them because they went to the pharmacy and they were giving gentamicin.
Wow.
Do you understand? Which shut down their kidneys. Wow. So if you're getting injections from somebody other than a doctor, make sure that they're a qualified pharmacist, somebody that knows the implication side effects, do you understand, of what they're giving you. I'm telling you, I've had 3 patients, unfortunately. One of them was able to come up, but the 2 others.
So they got the medication from the pharmacist?
They went for, they were treating them for infection, they gave them gentamicin. I've never used gentamicin in my life. Even before I became a nephrologist, I've never used gentamicin. So, not that there are indications for certain medications. So, there are medications that are safer than others. So, that's why you have to be in the hands of a professional or somebody that knows what they're doing. Because sometimes if you have 2 drugs that will do the same thing, but one is more friendly to your kidneys, your eyes, your ears, why would you go for the other one? True. So people have to be very careful because we do get these cases. Somebody's completely fine, they just went for malaria or cough, they now gave them gentamicin, now they're here doing dialysis for acute tubular necrosis. Wow. We have to be very careful who we allow to, touch our bodies or who we give our health to.
So now, once a kidney is detected early, what's the process like reversing it back? So
the first step is always controlling the thing that caused the kidney problem. If it is hypertension, control the blood pressure. If it is diabetes, control the blood sugar, control proteinuria, control other complications of the kidney disease like anemia, and then prevent complications like cardiovascular disease. Then we have to stop anything that can potentially worsen. So for example, if you're not hydrating enough, you should hydrate. Although we have to be careful when it comes to taking water because there comes a point in kidney disease where we actually restrict water. Wow. Especially to a point where patients are not making urine anymore, meaning they have very low residual renal function. So we tend to limit water for them. If not, they can have pulmonary edema, which is when water accumulates in their lungs, and which can be very, very dangerous. The salt intake has to be regulated. For us, we like salt, but ideally, we should not be taking more than 5 grams of salt a day. That's 1 teaspoon of salt throughout the entire day in our meals. Yeah, so that means we have to avoid processed foods. We have to avoid nephrotoxic medications, which are drugs that harm the kidney. For example, the gentamicin I was talking about, NSAIDs like Brufen, diclofenac, naproxen, piroxicam, all those NSAIDs, they're not good for the kidneys as well. Our diet, we have to limit protein, so red meat has to go. You can take white meat like fish or chicken. Okay, then limit foods that are high in phosphate like dairy, nuts, ice cream, and then potassium too. We have to be careful when it comes to that.
Oh, so now there's this new diabetes drug called SGLT2
inhibitors.
So now, these terms they said it seems to protect the kidney.
Yeah, well, SGLT2s or sodium glucose transporter 2 inhibitors have been very popular. Interestingly, they were first created as anti-diabetics, so drugs for diabetes. Oh. So they work by blocking glucose reabsorption from the kidney. So we lose glucose in urine. That controls the blood sugar. Then they now discovered that it actually reduces intraglomerular pressure, so it reduces pressure within the kidneys. So it can be kidney protective as well. Oh. And for patients that are having proteinuria, which is one of the things that can worsen kidney problems, they work. And then they've also discovered that they can be cardioprotective. So they're wonderful drugs actually. We use them for diabetes, we use them for kidney disease, we use them for heart disease.
So now, lastly, before we go, for people doing exercise and stress management, how does that help the kidney?
It helps a lot actually because exercise and stress management reduce level of oxidative stress in the body because lots of stress accumulates oxidative stress. You have a lot, as your body is trying to cope, it activates certain symptoms. The sympathetic nervous system releases cortisol and other hormones. At the same time, stress has been shown to dampen the immune system. That's why wounds have even been shown to heal in a slower way when somebody has stress. So because stress is not good for it, it also increases endothelial injury. So it's just a state of pro-inflammation. So stress management reduces that. Exercise also, it reduces oxidative stress, all that. So they can also help reduce the endothelial injury, reduce blood pressure, all that, and they can be good for the kidney. So they're recommended good ways to protect your kidneys.
Now, if I'm going to mention one thing that's going to make your kidney last long, what is that one thing?
One thing, check your blood pressure. When it comes in Nigeria, you just check your blood pressure.
Wow.
Because it's the biggest cause of kidney problems.
True. So now, if you could send one message now to Nigeria, for someone in the whole Nigeria, for someone that is in like stage 4 or stage 3 of like kidney diseases now, what's one message I can send to them?
I will say let's be optimistic. I know it can look bleak because kidney disease is often a progressive kidney disease and it's not reversible. But our target is to slow progression. So, and we're entering a stage now where renal replacement therapy is booming in Nigeria with the transplant industry coming into place. So we have other options, but it's just to remain optimistic, take your drugs, listen to your doctors, follow up during your clinics, and then just hope for the best. A lot of these patients actually do well on conservative management, and then when they do end up requiring renal replacement therapy, as long as the funds are there, they tend to do well. And then now there's transplant, which we're doing even in my facility, and then in other facilities in Nigeria. So they're doing, and the transplant patients tend to do well as long as they have an adequate donor that matches.
Wow. So there was Dr. Emmanuel, he's a nephrologist. He came on the show and he talked about most people having kidney diseases without even them knowing.
Yes.
What do you have to say about that?
Well, that's why screening is very important. Medical checkup. He's correct. A lot of these patients, we did a medical outreach not too long ago for World Kidney Day. When we went there, we screened patients with, we screened their urine, their blood. We picked up some incidents, even young people and old people as well, that had proteinuria or reduced kidney function and they were not aware of it.
Wow. So you can having kidney disease and you're working like nothing.
Yes, until you reach like stage 4. Your GFR drops to like less than 30 before you now start noticing leg swelling, fatigue, your blood starts to go low. Do you understand? So that's why your kidneys need you to be proactive. You need to actually screen yourselves for it regularly.
Wow. So now you've shared enough, like a lot of knowledge on these kidney issues here on the show, and I want to thank you so much for coming on the show.
Thank you.
Before we go, I want to know, like, why did you choose nephrology? One.
Okay.
And why did you choose becoming a doctor?
Why did I choose?
Becoming a doctor.
Okay. It was always medicine for me. Okay, there were 2 options actually when I was in secondary school. I wanted to either be a doctor or a lawyer because my father is a lawyer.
Oh.
We didn't have any doctors in the family as of then. But then as I, became older and stuff, I just saw that medicine, it was always medicine. I never really thought of anything else. Because I'm naturally a curious person, I always loved reading about the human body. I liked anatomy and biology when I was in school, and I liked physiology as well. So I think that was what just pushed me into medicine.
So you
I like knowing how things work.
So it was never all of a passion, or you want to see how you save the world?
Well, I wanted to save the world, but also, you have to manage your expectations. You do save lives, but then sometimes you lose lives as well. You can do your best and the patients still pass. So I think at the end of the day, somebody cannot just say they want to do medicine strictly for other people. There has to be a selfish element to it. If not, you'll not survive, especially in Nigeria. It has to be for you as well as for patients. Do you understand? So for the me aspect, I just liked learning about the human body. I'm very curious. I like interesting cases. But then on the other hand, I also like seeing patients do well and stuff. So you have to find a balance. It has to be for you as well as for patients.
So what about you going into this department?
Nephrology, okay. When I went into nephrology, I was surrounded by people that inspired me actually. So they were all hardworking, they were all very helpful, And then as I read the nephrology, the specialty itself, I found that it was very interesting. The kidneys themselves are very fascinating. The kidneys themselves are very fascinating. And then, you have a lot of cross specialty interactions in nephrology. You see a lot of rheumatology cases, cardiology cases, endocrine. You mix with almost everybody. And then there's dialysis medicine as well. I like learning about dialysis. There's a lot of physics there, so you have to learn as well. And then just seeing how patients can really do well if they are taken care of properly.
So now, if you're not going to be a doctor today, you'd have been a lawyer, and I'm wearing the wings.
Well, I would have been a writer.
A writer?
Yes.
Oh, for real?
Yes.
So now, during your, I think someone was saying before you move to nephrologist, like you have to like go to like all other departments.
Yes.
So now in all the departments that you've gone around, if you're not going to go for nephrology, which other one would you have picked?
The only thing I can consider, okay, my ideal second choice would be rheumatology. Rheumatology for all like autoimmune disease, all that, but I didn't rotate there because we don't have rheumatologists in Nigeria. In my center, we don't have a rheumatologist, so not everybody gets to do that. But I like reading it as a whole. So my idea would be rheumatology, but if not rheumatology, the next best thing would have probably been endocrinology.
Wow. So there's no pediatric, because you look like a pediatric doctor.
Fun fact, I actually went into medical school to be a pediatrician. Halfway through, I knew pediatrics was not for me.
Why?
For reasons we cannot talk about in this video. They know themselves, they know why.
Because see, from the outside, I think pediatrics looks so cool. Because if you go to the hospital, like they have a very different design, like there's like happiness on the outside.
Is that what you perceive? There's happiness?
Yeah, for me, I think there's baby smiling, the picture, like what was.
Exactly. So pictures, not that the doctors are happy, right?
So you're saying the doctors are not happy?
I'm not speaking for anybody. I would rather a pediatrician speak for themselves.
Okay.
But I think, they try there. One thing I like about pediatrics is their patients are absolutely like non-negotiable there, which makes sense. They're dealing with little humans, there's no room for mistakes in pediatrics. The pressure is immense. It's something that I found that I couldn't deal with. The pressure was too much in pediatrics. And just the patient population is so sad. It's sad. I used to cry a lot when I was in pediatrics. Seriously, like you'll be resuscitating. At least now, if I'm doing CPR on an adult, maybe somebody that's 19 years old, he has lived life. If he passes, unfortunately, it will be sad, but it's not the worst thing in the world. But for an 8-month-old baby, as you're even doing the CPR, your heart is breaking.
Oh.
So it's something that I just couldn't deal with, seeing mortality after mortality in children. It's not easy. Even pricking them, as you're pricking them, their mothers are crying. So what do you want me to do now? Me too, I'll start crying.
True.
Because it's not easy. It's just, let's keep it for the pediatricians. It's their own specialty.
True. So now, lastly, before we go, and all, like, what's, one advice you use in concluding this discussion today?
If there is one advice, it's really just to put more emphasis on general medical checkup. I know not many of us do, but we need to be checking our serologies, our BP, our sugar, our kidney function, our urine. By serologies, I mean hepatitis, HIV status, all that. So just screen yourselves. Don't allow the problem to come to you. Actually, a lot of people are afraid of looking for a problem.
True.
But I feel like the people that look for the problem, you are most likely to catch it in a stage where you can do something about it, rather than waiting for it to come hit you in the face when there's really nothing you can do anymore.
I have this nurse friend that every time I go to her, I say, please, can you check my blood pressure? Because we work in the same office. And she'll be like, this thing you're looking for, you're going to see it.
No, you're not seeing my blood pressure.
See, funny enough, I like checking my blood pressure because of the pressure it just puts here. And it's just so fun.
That's your reasoning.
Yeah, see, that's my personal reason. And, everyone I just want to say, please, can you check my blood pressure? Like, this thing I'm looking for, I don't find it.
No, by God's grace, you'll not find it.
I will not find it, please. Because of that, I won't stop checking, sir, because I'm like, this day I will not check now. I'm not saying anything.
Go and check.
Thank you so much for coming on the show, Doctor. I so much appreciate. And if you watch up to this moment, thank you for watching up to this moment. Please subscribe, share this video, and if you want to talk to the doctor, you can send us a DM or drop it on the comment section to shortly reach the doctor. Thank you so much, Doctor, for coming on the show. See you on the next one.
Thank you.
Bye.